You're listening to The Dental Guys, episode 35.
And it's the moment you've all been waiting for, The Dental Guys live from the first annual Voices of Dentistry conference, live at the Opryland Hotel in Nashville, Tennessee.
Today we discuss a topic that never causes disagreement, occlusion. And because we didn't want to upset anyone or cause problems, we titled this episode something completely non-controversial. Occlusion doesn't matter.
So hold on to your hats, folks. It's about to get real interesting. This week on The Dental Guys.
Well, I'm Wes, the Dental Guy.
And I'm John, the Dental Guy.
And I want to welcome everybody to East Tennessee. Well, really kind of Middle Tennessee, John, if you look at this. But we drove in last night we practiced till 5 o'clock yesterday. In fact, I think you were at your office till 5:30.
Yeah, I pulled out around 5:30. We drove. It's not
Right.
long for us. We're in East Tennessee, like Wes said, about 4 or 5
Right.
hours. Not too bad.
So you all are welcome to our backyard, right?
Welcome to
So
Tennessee,
This is our
y'all.
home. This is our home. And as Mark Costas said, we need to speak the slang. We already speak it because it's just part of our native language.
Part of it, man.
Yeah, so welcome to East Tennessee. It's good to have you here.
Yeah, we're excited about this because the format, there are a lot of different formats, for probably this meeting. They're going to be doing, some people are going to just be doing more of a presentation style. Some are going to be doing all PowerPoint. For us, we're not really going to do that. We're just going to do a show. So we're just going to kind of do what we would normally do. It's going to be just kind of a discussion back and forth. We're just going to run an episode, and this is going to be the episode
But I
that
think
we'll
that's
actually
the
put
thing
up.
here is that Alan contacted us months ago, and he said, we want you to come and present just as if you were recording a show.
Like a normal
so
show.
This is just like John and I getting together, having a discussion, sitting around with a cup of coffee, and talking about dentistry. And we like to talk about our craft. This is what we do on a day-to-day basis. We kind of geek out. We ran a little bit. And we're not afraid to step on toes.
Yeah.
And I think we might step on some toes today.
Yeah, we got a pretty controversial topic. It's not going to be maybe quite as crazy as the title sounded, but we want to get you interested in that topic. And, I think that one of the things, before we get into the meat of what we're going to talk about is, podcasting, we think, and we talked a lot about this on our show, that we think that the reason why maybe podcasting is becoming a bigger thing in dentistry is because of a desire for mentorship and maybe a lack of mentorship that we're seeing in maybe the private practice world.
So on our way here, we get a comment from a listener, like a book was written from this guy. And he said, I'm in an associate practice, and the senior docs want nothing to do with mentoring me.
Yep.
And we hear this time and time again. We talked to Gary DeWood about this, and what do we need to do to spread the wealth about what we know? And he said you need to find somebody to mentor, and you need to find mentors to mentor you.
Yep.
It's like Brandemark said. He said, surround yourself with great minds, and you're bound to succeed. And that's
Yep.
what we try to do on the Dental Guys, is bring it all together. But this is a great place for this.
Yeah,
The
we
Voices
think
of
that-
Dentistry.
Yeah, we think that that's what this is maybe about, and why so many people are into podcasting is because, you hear this guy that just sent us this message saying, the dentists I work for don't even want to talk about dentistry. They don't even want to, they just want to come in, they want to clock in, they want to clock out, and then they want to go do whatever they do, and they kind of hate dentistry almost. And so these, especially younger doctors, not even older doctors, but you're not
Right.
having, where do you learn? And a lot of younger guys maybe are not going to as many live meetings.
Are millennials different? Are they using media in a different way? I mean, we know that they are.
Right.
Millennials are considered anybody after, 1986 or something like
Yep.
that. And so we definitely aren't millennials. I was born in 77, John several years
just a
after
few years
that.
later.
And so,
So they're looking for a different way of using media. They're hunting for that, and we think that podcasting maybe fills that void. And that's why I think we have seen a growth in podcasting, not just though because we see. I mean, you look in our audience even right here, and it's not just millennials. There's a lot of middle-aged, maybe later in practice docs who are just finding that, hey, I'm on a drive in the morning. I want to learn something today. And so
Right.
we find that that's something that's cool to see that niche being filled. And we want to look at our show. We look at our show as, we've been mentored, and we want to pass that on.
That's right.
And one of the things that kind of transitioning into our show today.
Yeah.
So, we said in our little video there at the beginning that we're going to talk about some controversial topics today, and the title of the show is Occlusion Doesn't Matter.
Right.
But really, we want to talk about a specific type of occlusion.
I don't ever just bites anymore.
No, I don't care about that at all, ever.
Right.
Yeah,
no
we're not
calibration.
saying no occlusion matters, but we want to maybe try or attempt to put one aspect of occlusion maybe to bed a little bit, which is implant occlusion.
Right.
Implant occlusion.
Well, how many of us have been told in dental school, you better watch out on the excursive movements.
Excursives.
Working movements are going to kill your implants and cause bone loss and maybe even failure of your dental implant.
All right.
So how do we even start with this?
Well,
what are we going to use to prove our point
Right.
here?
So I think that if you think about what's changed the most, well, one of the things, there's lots of things in implants that have changed a lot in the last 10 years, but short implants have really come on in the last 10 years at being more accepted as the norm, whereas 20 years ago especially, that was, you just don't, 10 millimeters and above, that we don't even talk about a 6 millimeter implant. That's crazy talk.
I mean, put them in long, put them in
They'll never
deep.
work.
I mean,
you just need as much titanium as you can get.
I use zygomatics all the time.
Yeah,
42.
zygomatics on every patient. So
Right.
now short implants are on the market, and what is interesting about short implants is we're seeing success. We're seeing success, and we think that maybe...
Well, so much success that it's like there's no difference between a short implant and a traditional implant, which may be anything classified larger than 10 millimeters. Really,
Yeah.
I think the actual definition of a short
Let's
implant
define it.
is 8 millimeters or less.
Right.
And some
Most
of you might not
studies
think,
say-
I mean, there's some shorter implants out there. Most of the time, we were just looking at a treatment plan that John had, and we're looking at 6 millimeter implants.
Mm-hmm.
And I think that's a viable option. I place 6 millimeter implants. In fact, I've placed some 5.5s. And there are some of the shortest out there that are 5 millimeters.
So when you look at that, a lot of the studies that are out there, I think the first thing we want to dive into as we talk today is, what are short implants and are they successful? So let's talk we're not going to make the show, we have a segment of our show called Geek Corner. We're not going to go full geek on you, but we at least want to go through a little bit of
Geek out,
the
man.
research.
Just
Yeah,
geek it
it's
out.
hard for me not to,
All
but research on success of short implants. And now if you want to get into the nitty-gritty, we don't have a ton of long-term data. That is the truth, because short implants have not been studied in multi-center prospective trials as long as we have long implants. But what we're seeing, and if you go to the Academy of Osseointegration meeting, for instance, you will see from the main podium now saying, there's equal success in the studies that we have. Pretty much equal success, especially when you look at mandibular posterior splinted restorations, which is probably the one that's been studied the most. So I think we can say that, and you can debate it with us maybe after, but I think we can say that shorties do work.
Well, definitively, I think, one of the founding fathers of shorter implants, that passed away recently, Dr. Mish, and his retrospective studies on shorter implants and what they could do for us as far as the reduced complications, things like that.
Yeah, avoiding
and
anatomy.
And success rates. He showed success rates 99% and above on multiple clinical trials looking back.
So I think we're seeing success.
But there's complications.
So there's the other side of things, because you do have increased force. We've got a longer lever, so we know that we do have force. So what are the complications that we're going to see?
Screw loosening. So, that's the thing, is that no one wants the patient to walk in, and it's happened. And
It's a bad day.
my implant's loose.
Yeah, my
And
implant's loose.
it's really maybe, hopefully, hopefully,
Hopefully.
it's not the implant that's loose, but it's the abutment or the screw that came loose, and that's probably the top thing that we see as far as complications with shorter implants.
Right, because
But
it
there-
stresses the joint more.
But there
It
could
has
be
to.
something that could lessen that chancing. And this is where, if you're going to use shorter implants, anything 8 millimeters or less, we feel like that connection may matter.
Yeah,
and
starts to matter more.
Starts to matter more because we want that force to be transferred to that implant wall, which then drives force down deeper into the bone.
Yeah, we don't want the screw doing everything.
Right, so basically,
because
like
we're
an
gonna have more
external hex
complications.
short implant,
Right.
not a great idea.
Bad situation.
Even some of the shorter internal connected implants may not be such a great choice.
Yep.
But if you look at Bicon, who paved the way without even a screw, they have a long conus internal taper.
right.
You go Astra, they've got some great internally tapered implants. A company that we use,
Ankylos.
Ankylos,
Yeah.
So these things have helped to reduce the chance that
Right.
screw will loosen.
Right, but I think that the studies that are looking at complications, while they're not finding increased failure rates, they are seeing increased mechanical complications, increased issues with screw loosening. You could have an abutment fracture problem if you don't design your abutments properly.
Well, that's right there,
and
the next point.
what about that? What
Yeah.
about abutments? We know abutment
Oh, my
design matters,
goodness.
but what about abutment fit?
So, you know, Brad, the dental lab guy, has been on our show many times, and he has a $300,000 milling machine for just milling abutments in his dental lab. And that, I was there when he actually bought the machine overseas. And the interesting thing is that the implant companies ship him blanks. His machine will mill connections, but he doesn't feel confident enough that that connection can be milled accurately, so therefore he gets blanks from the manufacturer, OEM parts per se.
So do you think we need OEM parts? Is that what you're saying? Because I'm going to disagree with you.
Well, I know you are, but I think that it could
Bring it.
matter, because how many big companies, even Atlantis, I'll call them out, they've had issues. 3i's had issues with their milling machines and abutment fit. There's research articles in Jomi. You've
That's
read
true.
them yourself.
Okay.
Yeah, you've read them yourself.
But these labs, so here's where we want to make sure that we talk about when you're getting abutments from labs, are they actually FDA approved?
Right.
Are these actually gone through testing?
Right.
Or
So
are
that's
they
the
just
thing, is that
some dude has kind of reverse engineered it and it's a fly by night? To me, I look at, you know, if you've got FDA approval, that means it's gone
that's
through
just the government
a bending,
saying,
but
like,
it's
it's a
but
stupid
Brad
test,
has to
though.
but Brad has to send stuff to them, and they have
Right.
to come in and they have to put it through the Instron.
Put it through all
and-
that stuff, yeah. And
So-
it's very special testing equipment that's very expensive. And
But maybe on short implants,
It
it matters
matters.
more. Maybe.
Right.
So maybe you should be thinking about maybe we should use OEM parts.
more robust
I don't-
connection. And
I
then
don't
what
know.
about splinting? You know, we talk about, you and I.
Yeah, if you don't have a good connection.
Right, then maybe we need to splint. And
Splinting, we know, decreases your force, and it definitely is going to have an anti-rotational effect. So
right.
the screw loosening issue may be less of an issue if we're splinting. So I think that's. So we do have some complications.
So
That's what we want to
short
be.
implants work.
Yeah,
They're
they
successful,
work.
but you need to take into account
Yeah.
some of the complications that you could have.
Right. 'Cause
Choice
you're
of the
s-
type of implant that you use and shorter implications could lead to less surgery. I think that's
Right.
the thing here, is that why have a sinus lift, a
Right.
lateral window done,
Right.
or even a bump
Right.
when you can put a shorter implant in? I believe. You
Yeah,
know, I
or
sent
what-
you an X-ray the other day
Sure.
of a short implant. It was a 6mm implant, and it's got this long honking tooth hanging off of it, and it's like, I believe, man.
So let's talk about that a little bit, because the question is, why do short implants work? And I'm talking
Right.
about failure rate, because we've talked about, I think that we can say that there's some success, but why are they
I
working?
tell you what, I get sick and tired of this too, because every resident comes to me
Mm.
whenever I show them X-rays on this, and it's uneducation, really.
Yeah.
It's applying tooth knowledge to implant therapy, and we cannot do that.
Crown to root ratio.
It does not
That's
matter.
what you're talking about.
It doesn't
But
matter.
crown to implant ratio. So crown to root
Crown
ratio
to root-
matters.
Yeah, crown to
But
implant
crown
ratio.
to implant ratio
doesn't matter.
From a standpoint of failure, we're going to try to make the case today that it may not matter because we're not seeing implant failures as a result of
99% success rate on those thousands of
they're
implants,
working.
more.
They're working,
Yeah.
and so the question is, why are we still talking about implant occlusion? That's why that's why we're going to get to that in just a little bit. But so we talk about short implants. We've also got wide implants, right?
Right.
Short and wide,
Right,
because
right.
that's the thing that a lot of people are using these shorties for is,
Right.
you know, you
Meat
got
extraction, meat placement,
molar
like-
extraction.
right.
You want to have a nice, molar-sized implant for nice emergence.
But there's
so
some-
there's some pitfalls to that.
Surgical complications with that. You know, the
wide.
wider we go, the less blood supply that we have to the site. And so what we know now and what we've heard from innovators really in these wider body implants is that we really probably ought to stop at about 7mm.
Well, we need to at least, I think we can say,
far as
respect
width.
respect the buccal plate.
Right.
Respect the buccal plate,
We
the
start
facial
violating
plate.
that.
Because if you're just saying, well, we have an implant that fits the socket,
Bad news, man.
then we don't do that
Bad
in the
news.
anterior on number 9. Hopefully you're not doing that. Hopefully
But
we're
that
staying
used to
away
be
from
the
the
case,
buccal
though,
plate.
fill the socket,
But
though.
you've got like a keystone implant, a 9,
Right.
and you're slamming it in, and you're going, hey, it fits the socket perfectly, but do you have buccal plate?
Right.
If you're engaging buccal plate with that, so just because it's a nice short implant, you avoided a sinus
Blood
lift,
supply is
maybe
everything.
you compromise blood supply.
Blood
so
supply is everything.
we got to be careful with that, I think, of the short wide. But I think that the short part of that is the part that's working. The width is the concern.
The width is concerned.
But what about short implants? Are they easy to place?
Well, that's another thing is then we'll get into this a little bit later.
Because you hear this, implant companies are like, short implants, you don't even need to be experienced.
You don't need to be experienced.
Because you're not going near the anatomy, so it's easy.
Why are you placing it? Because one, you're really close to the nerve and you need a shorter implant, or you're really close to the sinus. So I think that do not throw caution to the wind here. Because if you're not an experienced placer with short implants and you're placing these implants even with surgically guided techniques, which most of the time most people are not. Even as popular as surgical fully guided surgery is, it's not in everyday practice.
Right.
And so
we're
we're taking a look at a
Corey
situation.
would argue with that, but it can be expensive.
He's printing his own guides back there in the back, so he's got a printing machine somewhere here, right? Probably.
Yes, in his pocket.
But MacGyver back there may be able to print a guide like on the fly, but most oral surgeons who are putting implants in, and now general dentists are actually putting more implants in than oral surgeons, are they using guided surgery? And if you think about it, if we're placing 6 to 8 millimeter implants, okay, how good are you at creating a 6 millimeter osteotomy?
Right, because you have to have stability.
You turn,
so
like
if you got a little wiggle,
right? If you got a little wiggle,
now the implant's not as loose.
It's loose, and so stability goes down. So is this where we say that surgical technique matters even more? Because we've talked about tissue and all that kind of thing, but now we're talking about less variability in movement of that drill, that handpiece.
Yeah. So I think maybe on the contrary, at first glance, you look at short implants and you think, well, this is an easier surgery.
Right.
And in some ways, it is easier on the patient. But is it easier to place short implants? I think we need to say you really need more experience.
I think your skill set needs
before
to step
you
it
start
up a
doing
little
that.
bit.
Or if your surgeons, if you're a restorative doctor, and your surgeons are saying, well, I'm looking into short implants. Are they doing a good job with their long implants? Because that's not something for the faint of heart. Because if you do have bone loss, now you've got a bigger problem because you don't have the ability. But on the other hand, of course, the other argument is now you can maybe recover the case more easily. So, but you do have to have an experienced surgeon, I think, to place these well.
And primary stability obviously could be an issue here. I think that we need to be very careful about immediately loading a shorter implant. And I know immediate loading is like the new thing. It's really not new, but it's new in respect that everybody's talking about it, that we need to be doing immediate loading. We need to do socket preservation and all that. And we believe in socket preservation using custom tissue formers and that type of thing, but immediately loading a short implant,
you're asking for trouble.
You're asking for trouble.
And now there are some studies where you see some kind of interesting case studies with people with splinted posterior restorations.
The great thing about long implants, the great thing about long implants is that we gain primary stability from the apical third. The coronal third of an implant is where we have less blood supply.
Right.
And initially, right?
So if we want to talk about what we have to watch out for, it's the inexperienced surgeon, and it's relying on it for immediate loading. And I think that's probably obvious to most of you guys that immediate loading with a short implant is a concern. But that kind of brings us really to like the main question here. So I think we talked about they do work. We have to be careful about who's putting them in. We got to be sure that we're respecting the difficulty of the surgery. We have to not think about loading them on day one, maybe necessarily. That's not what we're advocating. But okay, so if short implants are successful, the big question again was why? And the answer to that is that where does the force show up on an integrated implant? Where does the force show up? I mean, how far down?
Coronal third.
The coronal third.
Up to 5 millimeters.
So you're looking at maybe the top 1 to 2 millimeters.
Most implants 1 to 2 millimeters, unless you have a deep
maybe a really deep connection. So once an implant is integrated, what we would say is you could come in and cut off the apical. If you have a 10 millimeter implant, you could cut off the apical 7 millimeters. Once it's integrated, if you could somehow do an apico and cut that out, and you would still have all the force distribution. I mean, there's some force distribution, but it's not the main force distribution. That's why they're working.
The interesting thing about what you're saying there is that at the International Dental Show, there's actually companies selling 3 millimeter implants. They look like pancakes.
Crazy.
The problem with that is that it's kind of like a Bicon situation where it's a press fit restoration. You have no screw.
No room for
so
a
you're
screw.
tapping that restoration into place. And so lack of orientation per se, is a problem. There's no hex to orient your prosthetic. So
But
the reason why it works is because most forces are within that first coronal third.
Yeah.
But the risk there is that there's lack of blood supply.
Right. So if we can say that the force is in that coronal 1/3 or
then
especially the first couple millimeters,
we should be seeing failures.
then why aren't we seeing failures
How
with
many
these
people?
huge crowns and these little implants and all this force, and yet they're working?
How many people have, I wonder, in this crowd, have articulating paper forceps and articulating paper, Accufilm 2, Accufilm 1, whatever, you know, not the Madame Butterfly stuff, not the thick stuff, and are checking all of their implants on recare for lateral excursive contacts, working moments.
It had it when you delivered it.
Yeah, we got one
Right.
in the back. Corey, placing a lot of implants. You're not. Got a few over here. So, any
Yeah, you keeping it out of
working
excursives
moments? Yeah, are you
over
keeping
time?
it out of excursives?
But don't kid yourself that it's not getting loaded. I mean,
Right.
come on, it's getting loaded. And we're saying that the reason that short implants are successful is because it's not an issue. All this force that in the 90s, you had people advocating that occlusion
that come
was
from?
a major
does
major
that
cause
come
of
from?
failure, and it was, I think, because, and I love Mish, rest in peace. But I think that part of that was his biomechanic idea. Biomechanics saying, you needed, he showed some of these where he put 3 implants in for
Right.
1 molar, because he's like, oh, well, it had 3 roots, so you need 3 implants because biomechanics.
Yeah, his thing was that if a space is greater than 14 millimeters mesial to distal, that you put 2 implants in, number 19.
I remember
or 30.
going to lectures early
Right.
on in my career, and I heard him say, he's like, you got to put more implants in. He's doing, these amazing, 30 implants in one mouth, and it's like, because we don't want to have any cantilevers, we don't want to have bridges, we don't want to, because it's all about biomechanics. And I think what we're learning now with things like short implants, with things like
Right.
all-on-4, is that why is all-on-4 working? Why is
Right.
short implants working? Because we're realizing that it's not as important.
Angled implants, man, that just right there in itself. Now, I know we're doing bars and triangles and all that kind of stuff.
Right.
I mean, we can get into that. But I mean, holy smokes,
So,
dude.
so let's geek out a little bit on the research. So what does the research say about implant occlusion
Geeks
and
Corner right
failure?
here.
Geeks Corner, here it is. So, okay. Now, my mentor back when I was in dental school at UConn.
This is good because you got a connection here.
Yeah, he did a pretty big paper back in it was a late 2009-ish, and Tom Taylor, and he talked about an implant occlusion. Where do our ideas about implant occlusion come from? And he goes through all the classical literature that we have. And really it comes back to there's really one study that a lot of people cite,
Right.
done by a guy named Isidore. That's super geeky, but I know that. But they overloaded implants until failure. And what they would do is they would
How many
adjust-
times did they overload them?
So they would adjust, they would put it in hyperocclusion, and the opposing tooth would actually go
Impact,
away.
right.
And then they would hyperocclude it again. They reloaded the implants with higher and higher and higher restorations up to 3 times. And then they finally started to see some failure. Now, they didn't really quantify how much force it took, but it took 2 or 3 big-time overloads before they saw issues with bone. And what Taylor says is, he goes, this is really the only study that shows a dose-dependent response.
So there's
and
not
there's
been
so
a
many other
replication.
studies.
Right.
Right. Well, in 2014, 2015, you can read a couple of reviews on that where they say the evidence for occlusion in implants is very weak. We don't really have any clear. In fact, it may even be there's people that would advocate that force increases bone density by loading. As we know, loading
Right.
bone creates a denser bone. So there's really no. I mean, there's some people that will advocate it, but I think it's coming from more of that old biomechanical. We need 16 millimeter implants because we had a 16 millimeter root.
So this, and I kind of said sidetrack here, and we didn't talk about this in pre-production, is that, and it's not bad, all right? But here's the thing is that, more and more general dentists are placing dental implants. And we're choosing companies that they're relying on the research of, say, a Nobel or an Astra or a Straumann or an Ankylos, because these companies have millions and millions of dollars to spend to advocate the use of implants in certain ways or even surgical techniques. And so whenever you start to take away that research and people are moving away from these bigger companies,
Right.
and we're relying on old research
Right.
that's outdated to drive our evidence-based dentistry, it's no longer evidence-based.
That's true.
And I think we're going to see more of that.
And so let's get into this is where we're going to step on some toes, because the real reason that Wes and I, and this is going to be controversial, so sorry, but
not.
think the
I'm not.
reason we're not hearing about it as much on the big podium is because surgeons don't like this idea. They don't
wanna
want
own
to
it.
talk about this because if occlusion doesn't matter so much, then what is causing the failures? They don't like talking about that. Restorative docs, of course, it's great for us, right? Because we're like, oh, phew, don't have to worry about that so much. Not that we don't worry about it, but maybe it's not as big of a deal. But surgeons don't like that because now it drives us back to talking about surgical technique. Did you use the drill 70 times that you
Right.
were only supposed to use 10? Did you irrigate under your guide? Or
Right.
did you just put it on there and went, I can't really get an irrigant in there, we'll be fine this time? You know, those are the things that we kind of need to be talking about more,
Right.
that may be less about occlusion. And I think that's part of the reason it's hard to talk about
what
that.
we're trying to define here is that implants are 97% successful. In a lot of cases, they can be 99% success rate. So let's just say that during that, and here's the thing, is that I don't count early failures, which are
Yeah.
less than 1 year.
Yeah,
as
we're
a-
not talking about the early
We're talking
failures.
about long-term
Yeah.
failure after a year's time.
Yeah.
What's going on here to cause these failures? So 3% of failures, let's say that 1% of them is periodontal disease or infection. Okay?
fair. That's
All
fair.
right? Unless, what's the other 2%? You know? So
yeah,
you've
so-
loaded this implant at
Right.
4 months or 3 months. In some cases, you might have loaded it immediately.
Yep.
Okay? And now we're at 2 years down the road, and all of a sudden,
Right, bone loss.
bone loss.
Yeah.
And
so-
what's going on there?
and
Is
so
it an
you're-
overload?
Right,
Yeah,
so the
but-
surgeons a lot of times will go,
Oh, yeah.
Did you check your occlusion?
I mean, I've
Are you
had
checking your
oral
occlusion at every
surgeons, no
visit?
joke, call me on the phone and say, and I said, this thing's done. And he was like, well, you overloaded it, didn't you? You didn't put it in the right occlusion over there. Were lateral excursive movements on that lateral, and that caused the buccal plate to dehiss.
Right.
And I'm like, no, I don't think so.
So that's what we're
You know?
saying. If that's the case, then short implants shouldn't be working like they are because
Right.
they're taking that force from day one with long levers, high amounts of force, and we're not seeing problems. So what is the cause? If 1% is maybe infection,
Right.
we would say that surgical technique may be a lot more important here than what's really being talked about. We think that proper cooling of the bone during drilling.
Right.
We think that placing it properly in the crestal position, not just
Respect
not
to
leaving
tissue. We
threads
talk about
sticking
that all
out.
the time, is that this tissue thing keeps coming up.
Mm-hmm.
And the surgical technique is that in an oral surgeon's office where it is more fast-paced.
Yep.
And I think a lot of these guys do a great job. I'm not saying we know
Sure.
some great
There's
surgeons.
some great surgeons.
We know some great periodontists that are just doing it right, and they're doing it at a high level. But they take their time. They're not just slamming implants
Mm-hmm.
in. They're doing it with respect to good surgical protocols. You see all this talk about closed flap surgery.
Right.
And I wonder sometimes if we don't need to just lay a small little flap. Now, I'm not talking about just a big giant envelope and exposing buccal plate, but I'm
Right.
talking about
if it's
enough,
a healed ridge,
It's a healed
and
ridge.
you don't know where you are.
You don't know where you are. Even with CT-guided surgery, even the best guides
Right.
are not 100%.
They're not perfect.
They're not perfect.
So we at least need to say that some of it's surgical technique. We feel that's a big part of it. But then there's this what is the cause then of these cases where we feel like we had perfect surgical technique, we feel like occlusion maybe isn't the issue here.
Right.
It's a healthy patient. This is where we get into some interesting stuff that we want to talk about. What is a current understanding of what actually does cause failures, maybe things that aren't being talked about. We were challenged on this at the AO meeting, Academy of Loss Integration, a couple years ago by Thomas Albrechtsen, who was one of the original Brandemark group guys. And he talks about, he has a new theory, not brand new, but he's advocated this theory of this kind of steady state foreign body reaction. Essentially that the body, an implant, we talk about integration.
Right.
Implants don't really integrate. I mean, they do, but the body, it's a foreign body.
It's
I mean,
a biological
and the reason why the body,
process.
puts bone around it, according to Albrechtsen, is because it's trying to kind of wall it off. It's trying to say, we don't really want this here, so we're going to cover it up. And his idea is that there's this steady state where some host responses are going to be maybe more pro-inflammatory. That may cause less, more problems. Some hosts may accept it. Maybe there's medications. Maybe
Right.
there's, metabolic influences.
We first heard
was
about this
interesting.
actually back when we were in Sweden together, and he got on stage and they were talking about, maybe it wasn't him, but I think it was, is how far can we load an implant during the initial phases of healing? During that first 6 months or even that first couple of months when maybe integration could be pushed a little bit.
Yeah.
Meaning we can push that equilibrium to the positive side, meaning
Yeah.
cause
faster,
osteoblastic
faster integration.
activity. So you push that implant actually loaded in a certain way that actually pushes the equilibrium to acceptance.
Yeah.
And so as long as we keep equilibrium to the acceptance, to the
side.
positive side, we're fine.
Right, yeah.
Italy, is that you'll see all of a sudden you get 50% bone loss around a dental implant, but then you check it.
Right. So he's one of the few guys that can show a 30-year outcome. So he shows you an implant on a slide, and he said, and it's
So
50% bone loss, and he's like, so what would you do? What would you do in this? And of course, most of the people that take it out, graft, blah blah blah.
Yeah,
and
replace
he's
it.
like, well, what if I told you this was a 30-year follow-up, and here's the first X-ray took 30 years ago, and it looks exactly the same. He's like, why? Why did it lose bone and then stop? And this is where his theory kind of came from. So it's just an interesting idea. And there's been people that have actually looked at ways to try to achieve that. And one of the ways, and we talked about, bisphosphonates.
Bisphosphonates. Now, holy smokes, is that we only have 5 minutes left.
Yeah.
And how are we going to even talk about bisphosphonates?
All we got to say is that there was a study where they actually applied bisphosphonate
So
to the
sprinkle a little
implant,
sauce on the implant.
and then they put it in, and it actually held bone better. So that's interesting. Now, we're not advocating that. Don't say that we advocate that.
But what's cool about technology is that with growth factors and things that we can give our patient, we can actually force this equilibrium, no matter what the occlusion is, to the positive side.
Right.
So can you imagine immediately loading cases that we have host factors that are against us?
Right.
Like
And we can
periodontal
mitigate
disease and all those things.
Right.
And we can mitigate that by giving someone a growth factor. Maybe sprinkling a little xylitol on the implants, as we talked about in the previous episode. What's cool about this is that we know that this is coming up time and time again, and here's why. JPD mentioned it.
Yeah, they talked about it in their annual review. They spend a couple paragraphs talking about Albertson and saying maybe this is where we need to be going in our research about implant integration. Maybe this is why we're seeing failures in periodontal disease patients. Maybe because it's a pro-inflammatory metabolic situation that's causing them to have less of a steady state. Albertson would be a big fan of that idea. And we're not again saying we know everything about that, but we're just saying it's interesting. But I think what we are trying to say is
occlusion doesn't matter.
Occlusion doesn't matter.
Right.
When it comes to short implants,
Occlusion doesn't matter. When it
come
comes
on
to short
now,
implants,
it's working.
you cannot come to me and say, now I'm up for an argument.
Yeah.
Anytime.
Yeah.
You know, and we'll pull out the journal articles and we'll start geeking out with you. But let me just say this. We are so glad to be here at the Voices of Dentistry Conference, and this has been a great podcast. This will be released later on this month on our own channel. So I wish all of you right now, if you'll go on, you'll like us on Facebook, follow us on YouTube, follow us on Twitter. We're more active around conference times. We're going to be at the AO. We've already got our tickets. We're going to be going in May down to BioHorizons Conference. We're super stoked about trying to get we're going to try to get an interview with Tomas Likovicius, the guy that's talked about right now more than any reacher in dentistry about this tissue is the issue around dental implants.
Yeah.
And so I want to thank for everyone here at the Voice.
Thanks for putting this on. I don't know if Alan's still in the room.
Yeah,
Thank you for bringing us in. Thanks for having us here.
Right.
We appreciate you guys listening to us.
So one last thing though is that right after this, my wife will be at our booth over in that
podcast lounge.
Not the podcast lounge.
No, it's the other one.
Yeah, wherever we have our booth set up.
Yeah, with the swag.
The first five people that go there get a free coffee mug and custom coffee roasted by Wes and John. Okay?
Wes is on another level when it comes to coffee.
All right,
roasted at his house.
Roasted at my house.
Him.
Right, last Saturday.
Yeah, and what was the
Oh,
roast?
it's a Kenyan roast. So,
Kenyan.
Yeah, so it's so good. All right, Kenyan pea berry.
So come by and check us out. Get some free coffee and mugs.
Right. We've got shirts there for sale. Okay, we've also got coffee mugs if you don't make it there for sale. And we've got some of the products that we've talked about on the show.
Yep.
We've got that LED light that we reviewed. Magnification is the issue.
Yep.
So if you want to come by and put on some loops and like actually
XDR intro camera,
XDR intro camera,
some stuff we've talked about on the show. If you want to come by and check it out,
come by and check it out.
And so again, for Wes and John, we are the Dental Guys. Wow.